Hey team, let's jump into part 3 of our conversation on vascular lymphatic conditions. Okay, we're jumping into a big one here. This is DVTs, deep venous thromboses. We will see these, we will catch these, we will be responsible for helping prevent them. A large part of why we are so popular in hospital type settings is that we prevent them fairly effectively. So observe the picture there. You can definitely see that one of those limbs is likely to have one. So this is actually confirmed. So that's what an individual looks like with that type of skin tone with a DVT. Okay, so what is this? It's a venous thrombosis. This is a condition in which a blood clot or a thrombus forms in a vein. So the clot limits the blood flow through the vein and causes swelling and pain. Of all the different types of venous thrombosis, deep venous thrombosis is the most common. You can have a superficial venous thrombosis, but those are less common. They're more in the upper extremities, and we're not going to discuss those in this particular conversation. We're focusing on DVTs. Okay, so again, a blood clot which forms under the right circumstances, and those circumstances tend to be one of the following here. So we can sometimes have reduced blood flow, such as with immobility. The classic here would be somebody who is stuck in the hospital, or maybe they're post-surgical. So like you've had an injury, you had an ACL repair, and now you're just sitting at home. Or somebody who's in a plane, things like that. Somebody where you're really not moving. Conditions where there's increased venous pressure. So sometimes this can be kind of a compression sort of thing, or something is pressing on a structure. So for example, the body habitus that forms from pregnancy, or maybe there's a tumor pressing somewhere. So something like that tends to create the pressure. Otherwise, you can have a mechanical injury, such as we would see in a trauma or surgical type consideration, or sometimes from the lines that are placed for monitoring or administration of different medications. Also, sometimes, unfortunately, from individuals who engage in intravenous drug abuse. Then you can have increased blood viscosity. In other words, the blood is too thick. That's the layman's term for it. So the most common thing there are going to be the too high platelet count or dehydration. Those are the two most common ones. There are conditions which cause that too, but they're not particularly common, whereas dehydration and too many platelets, that's a very common hospital status. And then you can have anatomic or genetic etiologies, but for the most part, what you have are these reduced blood flow conditions with immobility, increased pressure, or trauma issues. Yes, there are other things such as acquired causes, and you can see the list there, but more so what we're concerned about are these classic 3 right here, the immobility, the high venous pressure, or the trauma etiologies. Again, so how do they look? I'm absolutely going to ask you this because sometimes the difference is surprisingly subtle. And I chose this image on purpose because, yes, you can see it, but it's not that obvious, not like the image I gave you on our intro slide. Pain. Only half of patients. You would think it would hurt more considering what it is, but it's actually only half of patients. Redness, assuming that the limb can demonstrate redness. Swelling, much more common. About 2/3, not quite 3/4 of your patients. Very, very classic. So what we're really looking for is potentially a combination. The edema or the swelling can be one limb, or it can be both limbs if you have a really, really high issue, such as up higher in the pelvic veins or coming up into the abdomen. So the skin tends to be hot, the veins tend to be dilated, and it's tender to touch. So not necessarily, some people can distinguish between tenderness and pain. It's not necessarily pain, it may be more tenderness, but basically a swollen, hot limb that hurts or maybe doesn't, maybe demonstrates redness or doesn't, there you go, right? So who gets this? Oh, it's all the time, but the vast majority of your folks are over age 40. Okay, that's the one we want to focus in on, over age 40. Yes, there are some demographic considerations, but really what we're looking at more is an age group, okay? Because there are better ways to look for how to determine risk than epidemiology, honestly. It's more so age here. So advancing age past 40, which isn't very old, right? That's pretty young, actually. What actually happens? You have 3 mechanisms. One is a damage to the veins wall, okay? So lots of things can cause that. An inflammatory state can cause that, but any form of damage, this is also the trauma etiology. And then you end up with blood flow turbulence. So let's draw an image that you've probably that you've seen before. So there's something there which has caused the wall to have a thickening or something like that. Blood normally flows like this, and the presence of this little protrusion causes this, okay? So blood flow turbulence, in which you have a site where the blood is staying still. What does blood love to do when it stays still? Form a clot, okay? So that's a hypercoagulability. So the hypercoagulability can be because of immobility, or it can be because of another pathological process. So the classic here is somebody who has chemotherapy is in what we call a hypercoagulable state. The ways that chemotherapy changes the body, like the secondary effects, mean they're more likely to form blood clots. There you go. So if they're in a state of hypercoagulability, and you'll hear that more often as we go through different conditions, that makes them more likely to experience the pathophysiology of a DVT. Now, there isn't an anatomic preference. Due to anatomy, the soleal veins are the most likely site. So this is in the area behind the venous valve pockets of the calf. So this is the lower limb below the knee. This is the classic site right here. When I think of the DVTs that I've seen, vast majority, and this is just Liz stats, but I'm comfortable saying 85% are in the soleal vein area of the calf there. Yeah, it truly is the most common area. I've seen a couple in the arms and a couple up higher, but yeah, no, it truly is exactly what the literature tells us. That actually matches with what I've seen clinically. Okay, so risk factors. Now on your study guide, I gave you some considerations, okay? So now as we're thinking about the pathophysiology, there is a formula, an algorithm that is used to predict the risk of DVT presence. So this allows a clinician to make a more reasoned judgment on, okay, I think a DVT might be present. And there's a scoring consideration here based on different criteria on the presence or absence of them. You don't need to know the scoring or the specific elements here. I am going to steer you a little bit. So let's talk about some pathophysiology that I will test you on because it makes sense with this class. In your second year, you're probably going to need to know how to actually perform a well scoring, and this will lay some baselines so that you can do that with greater ease. An active cancer diagnosis. Cancer creates a hypercoagulable state in the body. It changes the chemistry such that you're more likely to build blood clots. Recent immobility, so a person with a paralysis condition, or if they have a plaster cast, any form of casting, especially in the lower extremity, right? They can't move because they're in the hospital or because they've had a major surgery, and there's a time factor there. So pretty recent, right? 4 weeks, or they're recently bedridden. So for example, this is somebody who's in the ICU, and it's been about 3 days. Otherwise, it's all the things that have to do with the presentation. So basically what you've already learned, right? And there's another one here, but we'll talk about this more in class, but this has to do with using your good sense. Yes, the leg is swollen, but does something else make more sense in the presence of a DVT? You've just finished cardiac conditions with me, and there are quite a few that can cause swelling. So using your good sense, looking at the chart, you may think, okay, this limb is swollen. Does it make more sense for them to have a DVT as the source of the swelling or a different diagnosis? And that's what you put in the mix with your math, okay? So that kind of helps explain the logic of the Wells score algorithm. What do they do to determine whether something is there? There's a lab value that they're going to use, the D-dimer that you learned earlier. They can MRI, they can CT, but by far the standard is ultrasonography. They can actually watch the blood flow through the veins, and this is the standard. When you're on rotation in clinic, in the hospital, definitely stay around if the ultrasonography tech is coming over and see if you can jump in and listen to it so that you can watch. And it may be on one of your own patients, you know? And that way you can hear the sound of the blood flow as it bumps around if there's a DVT. Here on this image, I showed you, I had to hunt for this image, y'all. This is a DVT of the upper extremity. So I chose it for 2 reasons. It's this limb. So one is that this person has a darker skin tone, so the redness is not as obvious. The other is that it's kind of subtle with the swelling. But I'll show you some things you can note. Look at this hand, this limb here is the healthy limb, right? Look at the knuckles. See the lines here? The knuckles are more swollen here and the lines are less easy to see. Notice how here there's kind of a distinction as you come to the DIP, like it gets a little skinnier right here. And you don't see that as cleanly here. Notice how it's more of quote unquote sausage fingers, as one of my students used to say on rotation. So it may be a little bit more subtle, but honestly what you can tell is that there's a difference between these two limbs, right? With the swollen finger, the lack of distinction between the different limbs or the joints of the finger, with the PIP, the DIP, and things like that, as well as just kind of the wrinkling of the skin over the knuckle. Note that the MCP here is not as distinct, like this little mountain that should happen right here, that you can even see like the lines of the tendon, see right there? And you can't really see it on this person because the swelling has kind of hidden that tendon. So those are good ways to look for the presence of a DVT in the upper extremity. So just kind of giving you some clinical pearls there. Okay, so D-dimer. You've learned about this with another condition, but let's talk about it with the DVTs. So D-dimer is a waste product which occurs when a blood clot is in the body. Now the body is going to try to dissolve the clot, and it unfortunately isn't successful sometimes, and that's when you end up with a DVT. However, little bits of it are dissolving, right? And so those little bits contain the compound of D-dimer, and so that's when they're going to be present there. It's normally basically at 0 or a very, very low level unless the body is forming and breaking down clots. So the presence of D-dimer is very useful. What it's most useful for is actually for ruling out a DVT. So they use it as a screener, basically. So they're probably doing blood testing and they go ahead and look at D-dimer just to kind of see. Otherwise, it's not as good for ruling in. If you want to be really clean about ruling in a DVT, you need to do the Doppler, the ultrasound. So they're going to need to actually check for it. Otherwise, this helps whether or not you can rule out a DVT, which is really helpful still. Okay, so what do? Well, once the DVT is present, they're going to give you an anticoagulant, okay? So I have stars there just so you know. These are ones that we're going to talk about more when you come back to me in the summer. You don't have to know it right now. Just know that an anticoagulant supports the body's chemistry in breaking apart clots, hence the name anticoagulant, right? Coagulation being the process of forming a clot, this helps break it apart. So in really serious cases, they'll go in and remove it surgically. Otherwise, they're going to throw in a filter, and they're going to put it in the inferior vena cava, typically kind of like where the leg meets the pelvis, kind of in that territory. Otherwise, what they try to do is just keep the blood flowing while the person's on an anticoagulant. And so this can be a treatment or a prevention. So there's two terms that tend to get used, and it's kind of regional, kind of based on the hospital a little bit. And this is an intermittent compression device or a sequential compression device. So it's one of these things right here. And what's happening is this little motor right here is squishing. And so sometimes it'll squish here first, here second, here third, and then it repeats. It just keeps cycling through this squishing sequence. Hence the name sequential or intermittent compression device. There's different settings they can have. These are basically a standard now in the hospitals. The literature on them is actually surprisingly only so-so at their ability to prevent, but they do tend to be helpful in the fight. And I mean, when we're talking about preventing DVTs, I mean, personally, Lizzie G will accept all warriors. So this is a really serious condition that causes a lot of problems for people. And if it makes it into more critical parts of the body, like the heart, the lungs, the brain organs, then we end up with conditions of those organs, and that's terrifying. So I think these are great. So just as a little clinical pearl, patients are kind of black and white on these things. They either really seem to enjoy them or they really dislike them. It's like it creates a sensory overload and they hate the SCDs, so you might have to keep them compliant. Or they love them and they don't want to take them off. It's kind of funny how people are with them in terms of their psychology and acceptability of them as something that they have on their legs all day. So just kind of keep in mind that those are an option. So they're either prevention or once the DVT is there, it's part of the treatment of keeping the blood flowing. Ooh, we have a gold star slide. Why? Because we are powerhouses in the education of what to do to prevent or manage once a person has a DVT. And sometimes it's not rare for us to be the only ones giving these items of education. I can't tell you how many times I've been an outpatient. My patient has a complication. They go to the hospital for 2 days, come back to me. I'm reevaluating, and I go through, okay, did they talk to you about what to do? Because now you've had a DVT, and they're like, no. You would think that would be standard, and odds are very good, truly, in this day and age, that they received the education and forgot it or lost it. So you're probably just reinforcing, right? Let's assume positive intent of our hospital brethren, right? Okay, so they need to stay active. This is one of the big ones. They need to keep moving. They need to stay hydrated. DVT is more likely to form if you're dehydrated, remember? That's a pressure issue, as well as kind of a CVI issue. What you don't want to do is stay still a lot. You need to move around all the time. You don't get to cross your legs anymore. Some people like to do that. That's like a comfort thing. No, we're not going to do that right now. And they absolutely need to hop off the cigarettes. So if they weren't engaged in cessation, now is the time. Also, again, they can't get dehydrated, so they need to avoid alcohol intake. Other items of education, not unusual for your patients to have to travel long distances, and 3 hours is that boundary in which they need to engage in this little prevention protocol. So if they've had a DVT, they need to do this. If they're at risk of developing a DVT, they need to do this. So it has 2 arms of application. either known diagnosis or potential for the diagnosis. All of these things here make sense. All of them have to do with blood flow and staying loose and not getting dehydrated. The reason we don't want them to take a sleeping pill if they're going to hop into the plane is it's going to make them not do their exercises, right? They're going to be too immobile. So these are all things that absolutely I'm going to ask you about, and it'd be in the context probably of an appropriateness question. These are things that are more appropriate for your second year. This is like, you're definitely going to get tested on this in your second year, like in your INTEG class and your cardiopulmonary classes, but I might ask you elements of this, right? So there are different types of compression stockings that they need to consider. And again, the boundary is that 3-hour marker. So if they're going to be sitting in a plane or in a car for more than 3 hours, they need to consider compression stockings. There are specific recommendations. I'm not going to ask you this right now. It's just something for you to keep in mind. There are different classes, and it basically has to do with how much compression force they generate, and that partially has to do with the material. So know that that knowledge is coming in your second year. The big thing here is they need to be worn correctly, and they have to be the correct size. If they're worn incorrectly or the wrong size, you're actually creating the problem. You're creating compression in one spot as opposed to distributed compression. So that's not great. What's really nice is they can get covered by insurance, but what you really want to keep in mind is that what you want is a certified lymphedema therapist. That's a CLT. This is a really cool specialty to go in. And if you're thinking of becoming a lymphedema therapist, I support you. That's a rapidly growing area in our profession, and it's really cool. So basically, you learn how to fit these devices or these stockings and how to help the person manage their risk. So that's really cool. A CLT is really cool. They're often an OT or a CODA, but sometimes they're a PT or a PTA. Most commonly, you'll see them in an oncology setting. Again, because oncology creates a hypercoagulability status and does a lot of weird swelling problems. So very common to see CLTs in an oncology practice. This is a really cool specialty area for you to consider for your future career. So again, they need to stay on their anticoagulant if they're on it. Some people get kind of freaked out because of the bruising. That's a side effect of components such as, or a compound such as warfarin. And it's like, yeah, I know the bruising maybe looks upsetting, but it's a trade-off so that you don't get another DVT. So if they are on an anticoagulant and they're not sure about the travel precautions, they need to speak to their physician. So if they're super, super fresh, they need to get clearance to travel. So this is more for our hospital peeps. So if you have a patient in inpatient rehab, SNF, or hospital side like acute care ICU territory, they need to get clearance from the MD for traveling. And traveling defined as more than 3 hours of being seated in a car, train, bus, plane, whatever, any sort of stability or not immobility like that. And then I'm going to have you know this, okay? This is a good slide to know because these are anticoagulant precautions. Once a patient is on a blood thinner or anticoagulant, they might, depending on what the MD says, they might have to be on it for an extended period of time. So you might be seeing them for, like, I don't know, knee pain, but they're still on it from a DVT that happened, 18 months ago or something like that. So you need to be aware that basically they can have inappropriate bleeding. If the bleeding occurs in the kidneys, it can present with severe back pain. Otherwise, there can be blood in the urine. If they're having bleeding in the GI tract, that creates black stools. The formal term for this is also tarry, T-A-R-R-Y. And, just a little warning here, I'm going to say something gross. The stool or the BM will look like chocolate pudding. Yeah, it'll be kind of loose, but like it kind of stays together, and it smells weird. It smells like rust. If it's in the upper, that's in the lower GI. If it's in the upper GI, they may vomit blood. These are red flags. These individuals need to go into the emergency room because the blood thinner, in combination with an internal bleed, they're just going to keep bleeding internally, okay? So as they're losing blood volume, they might get weak or faint. So that's why these are red flags. These go to the emergency room, okay? Now, yellow flags, okay, so I'm required to teach you this, right? I'm required to teach you that an anticoagulant can cause bleeding into a joint. I got to be honest, I've never seen it. It is technically, physiologically, anatomically a risk. And one of my mentors when I was a new baby PT working in the cancer tower also went over this with me. And she's like, but Liz, I got to be honest, in 25 years of working in hospital-based oncology, I've never once seen it. So again, you need to know it. It's a risk. And what you would see is the joint would swell and hurt. If you see it, email me in the future because I really want to know what it looks like. I still have not met anyone who's seen it. So otherwise, this is much more likely here. Bleeding to the gums, excessive bruising, nosebleeds that don't stop. When they're on their menstrual cycle, it's ridiculously heavy. They can't stop swapping tampons and pads. Or they have a cut that just doesn't seem to stop. So These are yellow flags. It means they're setting on the dosage is too high. As scary as it can seem, this is actually still, it's call the physician and get your dose changed. You need to go see them pretty soon, day or two, but you've got some time. Depending on their presentation, you might be able to modify treatment and still see them. So the classic here for bleeding gums is they're brushing their teeth and all of a sudden their toothbrush is pink. Yeah, so that's the classic there, where they sneeze and there's blood in their hands or the Kleenex, something like that. So it's usually when they'll see these things, their setting is their dosing setting is too high. So that's what we tend to see there. Okay, let's go ahead and pause here and then we'll move over to lymphedema.